Hello everyone. Today we are going to discuss about the topic cerebral amyloid angiopathy. So a few words before we dig deeper. As the name suggests, it involves amyloid and deposition. There is a selective deposition of beta amyloid in the walls of cerebral vessels, mainly in the small and medium-sized cortical and leptomeningeal vessels. It has a close association with Alzheimer's disease. It is a cause of normotensive cerebral hemorrhage in older individuals. It also includes amyloid spills, incidental microbleeds, hemosiderosis, leukoencephalopathy. Coming to the epidemiology, its prevalence increases with age and people over 90 years of age, and there is 60% prevalence of amyloid angiopathy. And the prognosis is worse with increasing age and larger size of bleeds. There is no gender predilection. As previously said, it has association with Alzheimer's. There is a prevalence of 20 to 50% of amyloid angiopathy in patients having Alzheimer's disease. And coming to the risk factors, and it as I said earlier, old age and Alzheimer's are risk factors, and the presence of apolipoprotein E gene and as E4 gene is for cerebral amyloid angiopathy, and E2 gene is specifically has an increased association with increased risk of hemorrhage. And amyloid angiopathy is also associated with long-term statin therapy, previous history of use of thrombolytic agents, antiplatelet agents, and anticoagulant therapy. It is also associated with hypertension. And in familial, there are multiple genes, especially amyloid precursor protein gene mutation. So, regarding the pathogenesis, there is a focal deposition of amyloid fibrils in vessels. In later stages, these fibrils accumulate and cause degeneration of smooth muscle cells of media. The amyloid deposition weakens the vessel walls, making them prone to bleeding. So this flowchart explains the mechanism by which amyloid angiopathy causes injury. In one uh, scenario, it limits blood supply. There is focal deprivation of oxygen and increase in free radicals. There is oxidative stress, and this leads to cell toxicity. Amyloid and deposition also increases blood-brain permeability, blood-brain barrier permeability. There is extravasation of plasma proteins, which causes release of matrix metalloproteinases, increase in inflammatory mediators, and this causes focal edema and local tissue damage, where thereby this leads to partial degradation of the basal lamina of the vessel wall, and this leads to weak vessel wall, causing increased risk of bleed. There is a term called as double barrel lumen of this vessel wall. This is occurs due to obliterative intimal change, hyaline degeneration, and microaneurysmal dilatation and fibrinoid necrosis. This flowchart shows how amyloid angiopathy causes the other symptoms, where there is cerebral amyloid angiopathy related inflammation or angiitis. This is amyloid related vasculopathies, where there is dysfunction and leads to leukoencephalopathy, infarcts, hemorrhages, and it all ultimately leads to dementia. So there are 7 types of amyloid. It are amyloid beta, cystatin C, prion protein, ABRI-ADAN, transthyretin, gelsolin, and immunoglobulin light chain amyloid. Amyloid beta, it could be either sporadic or hereditary. Sporadic is associated with aging, Alzheimer's, AV malformation, history of irradiation. Hereditary is associated with A beta, amyloid beta protein precursor gene mutation, mutation of presenilin gene, and also associated with Down syndrome. Cystatin C is due to mutation of cystatin C gene. There is the HCWA Dutch type gene, and ABRI is a British, and A Dan is a Danish dementia. These are associated with mutations of those genes. And transthyretin mutation protein type is associated with meningocerebrovascular involvement, and also oculoleptomeningeal amyloidosis and polyneuropathy. Gelsolin type is associated with meningocerebrovascular involvement of gelsolin related amyloidosis. This is also called as Finnish type of CAA. And AL light chain is associated with cerebral leukoencephalopathy. Coming to the clinical features, CAA could be either asymptomatic, or it could manifest as hemorrhages, or it could manifest with ischemia, or it could manifest with transient focal neurological episodes also. And ultimately it leads to dementia. So hemorrhagic manifestations could be either symptomatic lobar, or it could be microbleeds. There is also entity called as superficial siderosis, and also it could cause focal convexity SAH. So this is superficial siderosis and SAH shown in this figure. And transient focal neurological deficits, these are sudden episodes of neurological events which is like a focal seizure activity, or it is due to cortical spreading depression. Ischemic manifestations are either in the white matter, or it could also produce frank acute infarcts. And dementia is mainly due to vascular dementia, where there is reduced blood supply and angiitis, as previously said in the pathophysiology. And there is a term called as CARI. It is called as cerebral amyloid related inflammation, where there is subacute encephalopathy and multiple other presentations. So, how to work up for amyloid related angiopathy? Initial imaging modalities, preferably MRI is used. CT is for acute symptomatic lobar ICH, and we can also use functional MRI and PET scan. And MRI, then we usually prefer the susceptibility weighted imaging. In functional MRI, as amyloid angiopathy has a greater predilection for occipital lobe, using fMRI, they have shown that there is impaired vascular reactivity in response to visual stimulation. And using PET scan, the Pittsburgh compound, there is increased binding in the occipital lobe. And if there is Pittsburgh retention, this has been associated with microhemorrhages. And blood test, they could and CSF, they could see that there is a reduced CSF A beta 40 and 42, and there is increased CSF tau. One example of an MRI of a patient who presented an acute stroke in the midbrain. The SW sequence shows there is a microbleed in the cerebellar hemisphere, and going up there is also multiple micro and macro bleeds in the cortex, which is both superficial and in the basal ganglia. Coming to the flare, there is also evidence of white matter changes and presence of virtual Robin spaces in the cerebral cortex. So, diagnosis of amyloid angiopathy is based on modified Boston criteria. Definite diagnosis is a postmortem examination. Probable diagnosis is with pathological evidence is with tissue biopsy, and probable CAA is where pathological confirmation is not needed. It is based on the history and imaging findings, where patient is more than 55 years old, having appropriate history, and MRI findings of multiple hemorrhages, preferably in supratentorial, varying ages and sizes, and there is also, or there is a single lobar ICH and focal less than 3 superficial siderosis, cortical siderosis, or disseminated more than 3 sulci siderosis. And possible CAA is where there is all these criteria, where MRI finding is less prominent. Presenting with dementia, a T2 emitted image shows a doubtful hypointensity in the right temporoparietal area and multiple small vessel changes, and there is atrophy appropriate for this age. Coming to the SW sequence, it shows multiple micro and macro bleeds in the supratentorial area, and there is also a foci of blooming in the right temporooccipital region, which is consistent with the subacute to chronic previous bleed, likely a convexity SAH. And coming up, there is multiple microbleeds, and there is also a focal superficial siderosis here, which is very evident here. Coming to CARI, which is amyloid related angiopathy. There is a chunk criteria for diagnosis, and definite is by histopathological confirmation and with the following it criteria, where there is acute or subacute onset of symptoms. The patient is more than 40 years of age and has at least one of these clinical features, either headache or mental status change or behavioral changes, focal neurological deficits, and seizures. And MRI shows there is a patchy or confluent T2 flare hyperintensity, which is usually asymmetric, and it could also have leptomeningeal or pachymeningeal enhancement. And there is evidence of pre-existing amyloid angiopathy within SWA sequence by macro bleeds or microhemorrhages or cortical superficial cirrhosis or recent or past history of lobar hemorrhage, and in the absence of any neoplasm or infectious etiology or paraneoplastic cause. So coming to the treatment, asymptomatic ICH, it is a routine standard care of treatment where there is a hematoma evacuation, BP control, and anti-edema measures, anti-seizure medication if there is seizures, and preferably used medications are topiramate, gabapentin, or valproic acid, and immunosuppression is preferred mainly in amyloid related angiopathy, but where there is associated inflammation, but it could also be tried in CAA. And CARI treatment, there is we can use immunosuppressive therapy, where this it has a monophasic course, hence it is improves with immunotherapy. We can use high dose corticosteroids, IV methylprednisolone 1 gram for 3 to 5 days, followed by rapid oral prednisolone taper, and one third of the cases relapse. So the differential diagnosis based on ICH, it could be either hemorrhagic tumor, it could be hemorrhagic transformation of this ischemic stroke, it could be lobar extension of a pre-existing hypertensive putamen bleed, or it could be AV malformation. Based on the imaging findings of pattern, it could all differentials are hypertensive microangiopathy, hemorrhagic metastasis, radiation-induced vasculopathy, and neurocystic sarcosis. This is a MRI of a 65-year-old male. The flare image, which shows diffuse temporal atrophy, severe atrophy, as white matter changes, Faseca grade 3, and there is also prominent Virchow Robin space, and there is an SWA sequence that shows infratentorial microbleeds, supratentorial microbleeds, predominantly in the basal ganglia region, and it is not seen outside the area and not seen in the cortex. So this is suggestive of a hypertensive angiopathy. So the prognosis is favorable only when there is bleed is smaller in size, or when there is it is in a superficial location, it is sparing the ventricle, and the patient has a good level of a higher level of GCS. It is unfavorable when the age is higher and when there is a larger bleed, and his recurrence is around 20%. Thank you.